Happy Doctor's Day to everyone. Hopefully everybody will get their fill of food in the various lounges around the hospital, which are having celebrations of Doctor's Day. For us here, we're doing water and breakfast sandwiches, like always. We wanted to make every day is Doctor Day here. So welcome to everybody, and look forward to that. Next week, we had a little unexpected opening in our schedule. So we have Dr. Braswell has graciously agreed to throw something together quickly and tell us a little bit about his trip to Tanzania. So we'll get a little, some pictures and stories from Africa. I'm really excited about that. As I met with Dr. Halverson last week, and he told me, you know, sort of their perspective, and I know that was a really valuable experience for everybody. Our CME color for today is going to be lime, and so without further ado, we'll get going. We have two talks this morning. First one is going to be from Dr. Chintlapudi, and then we also have Dr. Monk talking. So I'll invite Nani up here to be our first speaker.
I'm Nanisha. I'm the current research resident. I'm sorry, I'm getting a little bit over a head cold, so I sound a little funny today. But today I'm going to be talking about postoperative depression in an orthopedic population, an argument for SSRI or SNRI prophylaxis. So a little bit before we get started, I want to talk about why this topic is interesting to me. So I was very lucky that I not only had one, but two parents who were psychiatrists, and they somehow both had daughters who both went into surgical specialties. And now we recently added my brother-in-law and his twin sister who are also psychiatrists. So we have 4 psychiatrists in my immediate family, which makes for very interesting family discussions. But I really enjoyed exploring this topic and kind of seeing the overlap between our two fields. So I'm going to start off with a case like many of us do. So this is a consult that many of us have seen in the ED. This is a lady, she's LB, 31-year-old female who was involved in a GSW shooting at a nightclub. She had this ballistic tibial shaft fracture, and during this event, the shooter died beside her. So she underwent intramedullary nailing of her tibia fracture the next day. And at her 2-week post-op appointment, she was screened for depression, as many of our patients are in trauma clinic. So she, in the medical records of that event, she reported having nightmares about the event, difficulty sleeping, generalized anxiety about life, and all of this contributed to her inability to participate in physical therapy, as well as her perception of uncontrolled pain. So this is not an uncommon story that I think many of us have heard about before. And while the etiology of her depression may seem fairly obvious, I want to briefly touch about orthopedic risk factors for depression. So similar to what we heard, the trauma of the event can have lasting anxiety on patients' mental health, whether that's an accident, an assault, or a GSW. Secondly, the hospitalization itself, especially for patients who have prolonged stays in the ICU, can contribute. Then outside of the trauma world, there's other factors such as loss of independence and loss of function, especially in geriatric populations, who may require being moved into an assisted living facility or moving in with their adult children. And despite our best efforts, some patients do develop chronic pain, all which contribute. So why should we care since we're orthopedic surgeons? So I'm going to go through a couple reasons, some broad reasons about why we should care, and then go into the literature a little bit specifically for each specialty. So first, it's well established in the literature that depression is related to patients' evaluation of postoperative pain. So while you might not have a patient come into your office and say, hey doc, I think I'm depressed, almost every patient will come in with a complaint of postoperative pain at some point during their treatment. Secondly, there's a very real likelihood that we might be the only physicians that these patients have access to or ever get to see. And if that doesn't convince you, there is the fact that there is the emergence of value-based care and bundle payment models, and depression is one of the modifiable variables that can affect patient outcomes and how much a physician is compensated. So now that I went through some 3 broad reasons, I'm going to go into some of the literature that talks about this within each specialty. So as with most things, arthroplasty is usually ahead of the game when it comes to literature discussing modifiable variables. These are just 2 studies that are examples of the literature that show an incidence of postoperative depression in arthroplasty patients ranging from 2 to 3%. And there's a significant association between postoperative depression and increased risk of periprosthetic fracture, infection, medical complications, and non-home discharge. In the pediatric world, these patients are also at an increased risk, especially for conditions that have more of a chronic nature, such as scoliosis. This is one piece of literature that found as prevalence as high as 11% in their cohort, highest among patients who are age 11 to 16 years old. And they found a significant association with an increased length of stay after posterior fusion. And this is thought to be largely due to the fact that these patients have increased pain scores after the surgery, which leads to longer length of stays. And then in the hand world, there's also even higher rate of postoperative depression, about 20% in the literature. Usually this is thought to the loss of function when someone has a hand injury. And these are linked to lower short form 36 scores as well as PROMIS scores, both which evaluate functional and emotional recovery after an injury or a surgery. And then lastly, and probably the most obvious specialty that this affects is the trauma world. So the LEAP study, which is very well known, found that 42% of patients experience new depression 3 months after their injury or surgery. And they continue to have these symptoms at 2 years out, about 33%. And similar to all the other specialties, these are associated with poor functional outcomes and rehabilitation participation. So what can we do about it? So I think it's easiest to think about this in kind of 3 ways: prevention, screening, and treatment. So the first thing we talk about is treating it. So this is a study that we're actually starting here with Dr. Wally. She has a grant from the OTA. It's a randomized control study where we will have patients randomized into their SSRI, SNRI, or an observational arm and compare the outcomes between these 3 groups. So central to being able to treat them is also screening the patients. So this is another intervention that was launched in our trauma clinics, and the results were reported in JOT. So the way this worked was patients were first screened with the PHQ-2, and then if they were positive on that, they took the PHQ-9, and then if that still was positive for depression, then they were given a referral to behavioral health. So how successful was this? So over the time period that the results were reported, there were 476 patients screened. Of those, 12.6 met diagnostic criteria on the PHQ-9 to meet depression. And of those 8 patients, 13.3% of them sought treatment. So in these patients, suicidality was eliminated in all of them, and about 67% of them reported a remission. One of those patients was LB, the case that we talked about. So after she screened positive for depression at her postoperative visit, she was referred to behavioral health, where she was started on medication and given counseling services. And then at 12 weeks post-op, she was screened again and screened negative for depression, at which point she was discharged from the behavioral health integration, but she continued care with an outside healthcare professional. So I want to come back and talk about these 42 patients, these patients who did not enroll in behavioral health integration. So 62% said they were just not interested, 29% received other psychiatric care, and 7% cannot be reached. So this highlights an interesting point that even if we can identify these patients and we can treat them, there's other obstacles that prevent these patients from getting treatment. So what if we could instead prevent it? I think an interesting way to think about this is think about it in the way we handle infection. Would you rather treat an infection after it's developed, or would you rather prevent it altogether? And we do this in the way we administer preoperative antibiotics. We use the very medication that we use to treat the infection to prevent the infection. So what if we could do this with depression? So first-line treatment for major depressive disorder is an SSRI or SNRI. And I don't want to get too much into the pharmacokinetics of it, but it prevents the reuptake of serotonin and norepinephrine, all while maintaining a very low side effect profile, and comes in a variety of dosing and titrations. So looking at using this medication as prophylaxis for depression has actually been done before. It's been done in the post-stroke world. So this was a double-blinded placebo study, and patients were started on the medication 3 months after the index stroke. And they found that patients who were on the SSRI had a lower incidence of new onset post-stroke depression compared to patients who were on a placebo. This has also been looked at in patients after a heart attack. So after a heart attack, the current incidence of post-myocardial infarction depression is as high as 30%. This study not only proved that the medication is safe from a cardiovascular standpoint, but also found that patients on the SSRI had less new depression than patients who were not. So this is a really interesting topic that is being applied to a wide variety of patient populations. It's already being used in patients with hepatitis C, patients who have had a TBI, patients with new head and neck cancer diagnosis, and postpartum populations. So what about here at CMC? So I'm going to talk a little bit about a prospective study that I've been helping start as part of my research year. And we are deciding to focus primarily on geriatric new onset depression after a fracture. So the current literature states that the incidence is as high as 15% within the first year of a hip fracture, and that this peaks usually about 3 to 6 months after injury. And as we've seen before, these are associated with poor functional outcomes in rehabilitation and higher risk of refalling and refracture. So our population, geriatric lower extremity fractures, inclusion criteria are patients with no pre-existing psychiatric diagnosis and the ability to sign for consent. So our intervention is going to be an SNRI. So this is similar to an SSRI, but it also works with norepinephrine receptors. And we're choosing to use duloxetine. So this would be once a day at time of discharge. And duloxetine has the additional benefit of having neuropathic qualities, and it's been proven in the literature to be safe in cardiac patients. So duloxetine has actually been used in the arthroplasty world again. And this is a study that looked at patients who were started on the medication one day before surgery and then continued for about 6 weeks. So while depression was not an outcome that they measured in this study, they found that patients who were on duloxetine had better pain control and better quality of recovery, both on the emotional and physical functioning level. So our study, the outcome that we're looking at is going to be depression as diagnosed on the geriatric depression scale. So this is a 15 yes/no question scale. Over 5 questions counts as a positive screen for depression. And we chose to use this scale because it's been validated in the geriatric population. So it's been used to kind of distinguish between dementia and depression, which is very important when you're dealing with this patient population. So timeline-wise, our plan is to start patients on discharge on an SNRI. After that, it will be screened monthly with a geriatric depression screen for about 12 months. At 6 months, if they are continuing to screen negative, the medication will be tapered or discontinued. And at any point, if they screen positive, they will transfer the psychiatric aspect of their care to either their primary care provider or a psychiatrist. So looking forward, the goal with this is eventually to have some sort of a randomized trial. And the applicabilities of this type of research are very wide. We can apply it to pediatric scoliosis patients, polytrauma patients, and upper extremity injuries, as we're looking at the lower extremity injuries, and even spine and chronic pain patients. So the main takeaway that I want to have from all of this is you don't have to be involved in a trial like this in order to be aware of this issue and involved in helping your patients manage it. I want to touch very briefly on one resource. So this is the 988 hotline. So it's a suicide and crisis lifeline, but it's for more than patients just who are dealing with suicidality. And their website specifically has a lot of resources that are catered to a wide variety of patients from different backgrounds, different injuries, and even patients who are related to, or even family members who are related to patients with injuries. So you've got loss survivors and disaster survivors. So there's a lot of resources on this website to give your clinic staff or just be aware of and point your patients in this direction who might be struggling with depression after an injury or a surgery. These are my references. I want to say thank you to the whole research team that has helped me, as well as all my co-residents throughout preparing this presentation.
One question and one comment. First of all, great presentation. But as far as the question, is this just a treatment for the duration of that particular episode of care, or is this something that people need to be on
Long-term.
longer term?
So I think the goal is that we would be able to see if they develop depression. So if they develop depression during that time, then they would have their care transferred to a psychiatrist who could determine, I think usually the course of treatment for an episode of major depressive disorder is 6 months. But at that point, if they're screening positive, we would have a psychiatrist or their primary care manage them. For our study, if they screen negative at 6 months, then the medication will be discontinued, but we'll continue to screen them.
So as far as a comment, you raise a really important topic here as far as mindset. And one of the things that I think we should be cognizant of as physicians is we're uniquely positioned to provide people hope. And don't forget that. You know, sometimes we get buried in a 70 patient clinic and you commoditize patients. But I can tell you that in sports medicine, you know, when you're with me, I'll always tell you that I need to hear 2 things. I need to hear that, first of all, you know what's wrong with them. And second of all, that they're going to be okay. If they don't hear that, that's what generates second opinions and I think some of these emotional issues that you have. But, you know, we can't always tell them that everything's going to be okay because some of these are disastrous situations. But just about always you can give patients hope. And I think we should really focus on that.
It was awesome. Really cool stuff that you all are doing. Question I have for you on the pediatric scoliosis paper you threw up there, you had depression and anxiety.
Yeah.
So that actually resonated with me in the cancer world because when I see and talk to my patients, there's as much anxiety at play as there is just depression. I think sometimes the anxiety can lead to depression, but their primary symptom is usually anxiety. And certainly we do all the things like Dr. Mormon just talked about, you know, here's the plan, here's this, we've got hope, you know, all those important sort of discussion factors. But, you know, I think certainly an opportunity here. So a question, and outside of PEDS, did you see other areas, or even in that PEDS study, was the anxiety component improved by being on an SSRI? And then the duloxetine, does it have, you know, anti-anxiety elements to it too in terms of treatment effect?
So the pediatric paper, they didn't start their patients on an SSRI. They were just kind of reporting the incidence of depression and anxiety. They screen their patients for both depression and anxiety separately. And they found both of them were kind of linked to those outcomes that I've listed. However, they did list in their limitations that one of the things is like, it's hard to know which one weighs more into that association. Your second question, duloxetine. So it's very similar to an SSRI where it would also work on anxiety. There's some other antidepressants like Wellbutrin that would increase anxiety and make it worse. So I think that's kind of the benefit to using an SNRI that would kind of target both things.
Just in terms of screening, did that, and sorry, I could probably just pick up that pediatric paper and learn it, but you mentioned they screened for both. How complicated is the screening? How different is the screening? Does the PHQ-2 only focus on depression? Does it pick up any anxiety score? Is there an anxiety component to any of those?
So I think the PHQ-2 and the 9 do not. Usually they're given concurrently with a GAD score if you're trying to evaluate anxiety separately. In the one for the pediatric one, I believe they use like the SRS, which kind of addresses both. And then in that paper, they went on to have separate scoring after that.
Okay, thanks.
I got two questions. One's logistic and one's just a fun one. So the first question is, how logistically in the Charlotte area are y'all managing access to psychiatric care and referrals? I think it's been a problem with me in the past. So that's a logistical question. And then number two, what does your family think about the study?
So your first question, the psychiatric care. So I think that is a big issue that we have, is that it's very hard to get an appointment with a psychiatrist. Goal is, so the nice thing about geriatric populations is a lot of them have some sort of a primary care provider already. So they can usually generally manage the initial management of depression and then refer them to a psychiatrist. So even if it takes them 6 weeks to get in with a psychiatrist, at least their primary care is on board. So that's kind of the benefit to using this patient population. And of course, with the polytrauma patients or other patient populations, it's a little bit harder because they might not have established care. But this is kind of somewhere to start and then kind of address those issues as we go along. And what was your second question?
You want to know what your family thought of the study?
Oh, they think it's very interesting. I think both of them were kind of surprised they hadn't heard about like medication like this used as a prophylactic measure. So I think they thought it was interesting.
A couple of things about psych access. It's a huge issue nationwide. It's not just a Charlotte area issue. And it's not. It's some of it is access, and some of it is just there's not that many people that are doing mental health treatment out there, and so that's why it's fallen a lot to primary care. We were fortunate when we launched a lot of this work to be able to partner with behavioral health integration, and so they've actually been able to bridge some of that stuff. But it's even more of a testament to that perhaps we need to learn about some of these medications and feel comfortable starting them. And we've done that for a few years through the trauma clinic, and so I think people have a little bit more comfort with some of that stuff, as long as there's a safety bridge to it, and you know, people know that there's going to be at least a telephone call a few days later, see if there's symptoms for symptoms with starting a medication that we may or may not be comfortable with starting. But I think
Orthopedic surgeons are dangerous because they're well informed from their test taking history, because they're all good at test taking. They all know that starting an SSRI or an SNRI can be associated with suicidal ideation or thoughts. So that's why I'm sure the room says, "Oh, I don't feel comfortable starting one." That's just
Yet we use psychoactive medications all the time.
Yeah, I mean,
I
mean, we're throwing them out there like
crazy. So that's what I was going to ask you just now, Joe. Exactly that question is, as an orthopedic surgeon, neurosurgeon, seeing these patients, what is more likely to cause suicide or any other negative effect, starting them on this medicine or giving them another narcotic prescription?
I don't know those. I don't know the incidence of it, but I do know the end result in this country. Suicidality after starting at one of these medications is much lower than the death rates that we're having around the opioid crisis. And it's interesting because we started doing a lot of work on benzodiazepines early on, and people didn't think it was important. And then now it's actually people are realizing that benzodiazepines are a huge disaster in our society. And so one of the things I will add about the anxiety piece is we have some really nice resources that Dr. Wally put together. And we have this QR codes and our thing on cognitive strategies. They were initially they're really put together for pain management, but it's an anxiety-based strategy. So those can be very, very helpful. Although in the US, we'd rather take a pill.
Yeah, I mean, I think that's the important thing. This is the kind of research that can really be paradigm shifting in terms of saying, what is our first line for dealing with this? I've seen back pain studies looking at starting with sleep modification and antidepressants as a primary first line treatment for back pain, as opposed to all the other crap we do for people in the back pain world. And those things are typically better.
Well, so that's where I do want to pivot a little bit and talk about the therapy component, because I think for crisis coping, therapy is just as important, if not more important than a pill, as you say. It's harder. But I was wondering if we are going to have the behavioral health integration group include psychotherapy as part of this intervention, or if we're going to have some way of controlling for it in the study so that we can actually parse out the actual prophylactic effects of medication, not including therapy as part of.
That would be something good to involve, because a lot of the studies in like post-stroke and post-heart attack, they have a control group or a different group that went under like cognitive behavioral therapy to kind of compare incidence of depression between those who had that type of therapy, the medication, and placebo.
I have a question. Great talk, thank you. In the spine literature, and I'm sure it's similar in the general orthopedic literature, is tremendous amount of evidence on depression, anxiety, and mental health and outcome. Most of this evidence over 20 years is what's in CBT, cognitive behavioral therapy. And my question to you is, coming from a family of psychologists and doing a deep dive on this, we've been focusing on CBT upfront, through care, post-operatively. Would you recommend pharmacopoeia or what traditionally has been the gold standard of CBT in the general orthopedic and spine space?
So I think
Obviously, both is an option, but if you had to look at one, what would you recommend?
I think that you always want to be careful about adding more medications on, especially in a geriatric population where you're trying to avoid polypharmacy. But I do think that medication offers benefits to patients who might not have access to therapy. Like we talked about, it's very difficult to get into those types of services, and they're very expensive. Insurance doesn't always cover those. I think that in an ideal world, like you said, everyone would have both. But I think this is an interesting way that we have some sort of an option that we could use prophylactically to help prevent this, where therapy might not be the most effective in preventing new onset depression. So this would be kind of like a tool to have into your toolbox and help your patients address something like this. I think it's hard to say which would be better because I think both can work differently.
And prospective pharmacotherapy is probably going to hit those sort of middle players who didn't quite have a high enough score to seek referral. I mean, I think the nice thing about the study design is that it's only the people who continue to screen positive or worsen who are requiring that. Because I mean, that's the rate limiting step. Like, look, primary care pediatrics, all the pediatricians are having to learn how to do, depression treatment because there is no resource to send them to.
Spot on access is the major issue traditionally to mental health treatment in our population.
Are y'all using virtual CBT or are y'all using in person?
I've started using actually a company that uses virtual VR headsets, virtual weekly master level therapist. But we haven't scaled that and seen it say by any means. And then we are part of a spine destination and direct employer program, Center of Excellence, that actually does require neuropsych or CBT as well. So I mean, in the spine universe, as Josh can tell you, there's a well-recognized need for behavioral management. But it's like 1% of our practice.
JJ.
Can you touch on the rationale for using an SNRI over an SSRI for prophylaxis.
Yeah.
A lot of us learned that SSRIs are more commonly prescribed, less side effects, SNRIs.
So a couple different reasons. One is SNRIs have the neuropathic quality, so we felt that was valuable. And then we actually met with Dr. Nagy, who's one of the pharmacists at the hospital, and asked her about those side effects because I was concerned about something like that with duloxetine specifically. And she said the types of side effects that are usually reported with an SNRI are not really clinically significant in this patient population. So having the added ability to have a neuropathic quality was valuable enough, especially thinking about how we know that postoperative pain and depression are very closely linked. Having that extra quality would really make it more appealing for us.
And Dr. Wally's study will compare the two.
Thanks, Nia. Excellent talk.